Hello, and welcome to Key Insights from the Great Debates in Inflammatory Bowel Disease meeting, which took place here in San Francisco. I'm Dr. Joel Rosh of the Goriab Children's Hospital, where I'm the Director of Pediatric Gastroenterology and Vice Chairman for Clinical Development and Research Affairs, and a Professor in Pediatrics at the Icahn School of Medicine in Mount Sinai. And I'm joined here by Dr. Marla Dubinsky. Hi, Marla.
Hi, Joel. Nice to see you. Another great meeting. Which has been fantastic to be a part of now for, I don't know, however many years we've been doing this. So it's great to have you as a partner as usual. So I want to start by just figuring out, you were at the pediatric meeting and the pediatric side of the meeting. We have a joint pediatric and adult focus meeting, and we divide the meeting into 2 days. So tell me some of the key insights that if you were to tomorrow go back to your practice or want to share with other gastroenterologists that weren't able to join us. Tell me what are some of the key insights you want to take away. There was a lot of discussion about epidemiology, risk stratification, therapeutic drug monitoring, pouch complications. Kind of tell me what you think is really what we should think about tomorrow when we go back to our practices.
Oh, absolutely, Marla. There was a lot, you're right, there was a lot covered, and I'm looking forward to getting back to the office on Monday and putting it all to work. Sure. We were treated by Eric Benchamal from Ottawa, opened up and gave us some of his data as well as others on the epidemiology of IBD. I think we all recognize that the incidence and prevalence of the diseases are rising, and it also feels like the severity of the disease is increasing as well. And Eric showed us that in Ottawa, where South Asian immigration is actually one of the largest groups that are coming to his area, there's a clear rise as immigrants come to Ottawa. Per decade of being present in a new environment, the rate of IBD increases, and it seems to be more impactful depending upon your age. So for us in pediatrics, a pediatric patient who immigrates is much more affected than, let's say, someone who's 60, 70, or 80. So clearly, it's that clear message, genes aren't changing. Why are we seeing a rise in the disease? Well, there's environmental factors, and that's really what's inputting. Exactly what is that environmental factor? He threw out some ideas with some data attached to them. Is it pollution? Is it urban versus rural? And those, again, are just associations. And what is it about those particular environmental factors, or are they just surrogates for other things in the environment? So a lot to think about, but certainly some real data that these are diseases that we're doing to ourselves. There's something in the environment that's making them rise. From there, Robin Sokolow from Weill Cornell really gave us a great talk to make us think about the fact that we talk about ulcerative colitis and Crohn's disease, but in truth we're talking about many diseases under those broad umbrella headings, and that there are different phenotypes, and we all recognize we take care of patients that we diagnose as mild and stay mild, and probably whatever we do they'll be mild, and thank God for those. But then we have those patients who are rapidly progressive, and how do we find the patient who's going to be sick tomorrow and make a difference today? She showed that there's some real data that ileal involvement is a bad prognostic indicator, the ileoperianal phenotype, and brought forth the fact that pediatrics is so different in so many ways than adult IBD. It serves as a paradigm for the fact that there are different phenotypes. And perhaps that's just a geography. Pediatric IBD has more of the bowel involved, whereas you'll see the just ileal phenotype more commonly in adults. It's almost much more prevalent to be ileocolonic in kids, and maybe that's why the disease is more prevalent, more aggressive. In ulcerative colitis, where 2/3 of adults who have just left-sided disease, 80% of kids have pancolitis, so maybe that's why ulcerative colitis is a more aggressive disease in pediatrics. So it really teaches us to think differently, not just what do you do for your Crohn's patient, as opposed to what do you do for this Crohn's patient. Really, really good talk to break that out. And then Jim Markowitz from Northwell on Long Island took that idea, okay, now that we have our different phenotypes of disease, how do you treat them? What's your goals of therapy? And broke out the fact that for a long time we were just happy enough if our patients told us that they were okay, clinical remission, if you will. And that's a very good marker for quality of life, but it may or may not tell you what's actually happening in the bowel. And we all hope for that great surrogate, or at least biomarker, whether it be fecal calprotectin or CRP, probably the best that we have today. Those are what Jim said we can put our hats on for today, and obviously we are looking forward to tomorrow for something even better. And then the holy grail of mucosal healing, and the fact that you can get 3 observers and have 3 opinions of how the mucosa works. So certainly it's a great qualitative endpoint, but the devil becomes in the details. And when you talk about surveying the mucosa in a disease that might involve both the small bowel and the large bowel, can you get to where the inflammation is? Well, the answer is yes. With a little colonoscopy, we can see most of the mucosa that's involved. But should we be happy enough that it just looks good, or should we be going for true tissue healing and going for histological remission? Open questions that need to be looked at. But right now, probably our goal should be quality of life and clinical remission, and certainly normalization of markers like CRP and calprotectin with judicious use of endoscopy, especially when we have that question, how well is my patient really doing? So for me, it became a very practical discussion of recognizing that when I care for a patient, I need to think beyond just how are you doing today, but I really want to make sure I'm changing the disease so that tomorrow will be better for them as well. Speaking of tomorrow, you then got up and gave us a look to tomorrow and talked about how we can optimize today's therapy. And it was a fantastic discussion about therapeutic drug monitoring and how if I put you on a therapy, I want to make sure I'm using that therapy the right way. And you took us through the concepts of the past where we were reactive in our testing. So if a patient isn't doing well, I might measure their level of anti-TNF, and lo and behold, look at that. It's lower than I wanted it to be. But maybe that's not thinking about it the right way. Maybe what I need to be doing is testing while you're doing well to make sure I'm using the drug well to keep you at that point. So a real proactive testing strategy. The idea of when I'm done with induction at that first maintenance dose, getting a level and seeing that it's therapeutic. But also you brought forth the idea of maybe even looking earlier than that, maybe midway through that first maintenance period. So for my Remicade, let's say, at 4 weeks, and seeing, can you really make it out to 8 weeks, or am I just dosing it wrong for you? And a real thought towards personalized medicine. The idea of a dashboard and guiding therapy in the future. So I could look at different markers even before I start your anti-TNF, and I know you're a 13.3 milligram per kilogram patient and not 5 or 10 in this unit dosing, but real flex dosing and being flexible strategies as we get more science behind it that will really know the markers and better understanding of how these drugs are cleared. And as we move on further into armamentarium biologics, the anti-integrins like vedolizumab, we're going to have other mechanisms of action soon, like ustekinumab, and how are we really dosing those medications, and are we doing it the right way right from the start? Very, very important if we're going to get there for our goals. And then lastly, we closed out the day in pediatrics talking about problems down below. So the patient with the pouch procedure after a colectomy for ulcerative colitis, we recognize that at least 25% of our patients have pouchitis, about where the pouch itself becomes inflamed. And how do you approach that patient? You want to make sure that the mechanics are right. You want to make sure there's not an anastomotic stricture and that the outlet is open. And you need to get cultures and make sure it's not infectious. And you need to take a look, because not all pouchitis is microbial in nature or autoimmune in nature, but it can also be ischemic in nature. And looking at where the inflammation is it along the anastomosis? That can be more ischemic. Is it the whole pouch? That makes you think more about bacterial role. Antibiotics like Flagyl and Cipro can be very helpful in those patients. And in the relapsing patient, maybe that's a role for probiotics. A lot of the questions from the audience were, what about probiotics? Maybe that's a place for them. And last but not least, we talked about perianal Crohn's disease. And really it's a model of the IBD center, where you really need the medical side and the surgical side working together. The surgeons helping us as medicine people to drain the purulence, get on top of the inflammation by getting all the pus out first, and then we can come in with our medications in a meaningful way to help calm the area, bring tissue healing, and resolve a problem that can be very troublesome for our patients.
Great. I mean, I think you really highlighted, again, just like our day today on the adult side, the pediatric side, the topics were such, what tomorrow I need to do when I go back. I need to think about all the elements of risk stratification, which I think you bring up is such an important point, but it ties to the treat to target concept as well. I mean, one of the most important things I think about these meetings is being able to have kind of different opinions for the cases we present. You know, it's not just about kind of the didactic key insights. I gain a lot from hearing about how we all practice a little bit differently. All have the same goals in mind, but we come at things a little bit differently. You presented a case of a UC patient. You talked about a patient going on mesalamine, and then the patient subsequently flared, and discussion on what would be other treatments that come on board. Let's talk about the role of mesalamine in children, because I think we may view mesalamine a little bit differently than some of the adult management of UC. I don't know, is that because you think so many of our kids present with pancolitis, which if you look on the adult data, more don't present with pancolitis. Now, they can progress to pancolitis, but we are about 80% of our kids present with pancolitis. So we're already dealing with an escalated phenotype. So a patient comes in, you presented this child, they came in, mesalamine had been their therapy of choice. Is there a way for us to know upfront which kids are going to be okay on mesalamine as the maintenance strategy? I think because there's such an important leap for families to go from a Pentasa-based or 5-ASA-based, which to them they accept. But the minute they go beyond that, we're typically in UC, since if we're talked about what we talked about today, where thiopurines are probably not going to be our maintenance strategy, we're automatically talking about a biologic, most commonly. Do we know how many patients, in peds in particular, actually will still be on a 5-ASA at a year after starting it?
Right. So those are key questions, and they really cut to the heart of phenotyping our patients and risk stratifying and knowing the future. The best data we have right now is retrospective from the Pediatric IBD Collaborative Research Group that showed us that 40% of our UC patients will be in steroid-free remission at 1 year on just 5-ASA. The key, obviously, is just what you put your finger on. Am I in the 40% or am I in the 60%? And we don't really have the answer to that today. There is the PROTECT study, which is an NIH-funded multi-center study. It's a translational project collecting microbiome, genetics, tissue markers, serology at the time of diagnosis. So then we can follow this well-characterized new cohort of UC pediatric patients and look how they did over time, and hopefully we'll have those markers. So at the time of diagnosis, I could tell Mrs. Jones, listen, Johnny needs 5-ASA, gonna do fine, or this is really unrealistic therapy and I can show you why. Until we have that time, we have an era where we need to follow our patients very carefully. We certainly, and we talked about it somewhat, right, that any home therapy adherence becomes very important, and is the reason that it's only 40% because the other 60% didn't take the medication, or is it because they really have an aggressive disease? It's probably a mixture of both. So I use that same statistic to my family, 60-40. And you've got to know when to move on. I'm on a therapy that's not working, like this patient that we presented. Every reason to think they've been very adherent. This therapy is no longer working for them. Their disease is progressing. Make sure that the symptoms really are the disease. Calprotectin is elevated. Maybe even it's time for another scope and take a look. Make sure you're not moving on therapy for functional factors, but really inflammatory factors. And if indeed this is inflammation despite adequate therapy with mesalamine, it's time to move on. And I think you're exactly right. We have different options of biologics now that work, are effective, and should be employed in that scenario.
Because I think, if pancolitis itself is a risk factor for beyond 5-ASAs, we need to know that. And the question is, like in these retrospective or cohort studies, did they risk stratify based on disease location, for example? So who knows, maybe someone with that 20% who were left-sided did better with mesalamine than the PANS. I have no idea. We do know that obviously anyone with CRP elevation with UC, because UC not often has CRP elevation, someone with low albumin, someone with deep ulcers, someone who is having nocturnal symptoms, someone who's having need for blood transfusion. I think you and I both agree that that's not an individual who you're going to send home possibly on mesalamine, that you're probably going to think a little bit differently about the type of therapy when you're transitioning inpatient to an outpatient. But a purely outpatient, we're probably going to try for the 5 ASAs before we start talking automatically about next steps. So the conversation's a little easier, I think, from an inpatient, because you probably started whatever your maintenance strategy may be in biologic.
Oh, I think you're absolutely right. I think one of our biggest challenges today is taking care of the mild patient. Yeah. The patient that you described, the really sick patient, we know how to take care of them. It's the mild patient that gives us the biggest pause, because we don't know, are you going to stay mild or are you going to turn into that really sick patient? And for sure, as a physician, I would like to preempt and keep you well and keep you from progressing. So I think our biggest challenge is in that mild patient. That's where we hope to get some really good markers, because you bring up great clinical points and clinical markers of inflammatory burden, looking at the markers that we have today, like albumin and CRP, and endoscopic findings. But for that mild patient, we need something beyond, because those markers aren't there because they're mild. It's an excellent point.
You know, it's funny, I'm even thinking that we have a lot for the moderate to severe, leaning on the severe side. And I think we're okay with mild. It's even the moderate patient that I'm not sure how aggressive we need to be. It's funny, that moderate patient always gets left out, because indications are mild to moderate and moderate to severe. What about just the moderate? And, you know, is that patient someone that we're under treating and we're accepting and kind of we downgrade typically? We're like, oh, you're just mild. You know, it's very interesting concept to think about that moderate patient that kind of gets left in the middle. It's like the middle child. It's like, what do you do with that middle child? And I think probably if we take all of the insights from today, which I think there was such a huge component of that objectifying and treat to target concept that we took away from both Saturday and Friday's discussions, is that no matter what treatment, and even probably more so in the child or the adult even who's on a mesalamine, should you be using objective measures even more so than using symptoms to help you discuss escalation?
Yeah, so disease monitoring is a very key, and treating to targets can be very key in that population for sure.
So thank you so much for sharing with us your day.
Thank you, Marla. And thank you for joining us on the key insights from great debates in inflammatory bowel disease from San Francisco.